Good afternoon. Today's topic of the lecture is management of midline diastema and spacing orthodontically. So, what is a midline diastema? Diastema means a gap. So, midline diastema very commonly refers to the space between the two upper central incisors. Coming to the spacing, spacing is very common in common malocclusion, which we see. The spacing can be isolated to one or two teeth, or it can be generalized. So, generalized spacing we will see between all the anterior teeth, upper and lower arches, or sometimes it can even extend to the premolars and molar region. So before we start planning the correction of malocclusion, we need to remember these three steps. That is, for any malocclusion, we first have to eliminate the cause or etiology, then do the active treatment, and also plan the retention. So these three steps are basic for any kind of malocclusion correction. So coming to the etiology of spacing. So initial spacing that we see is in the primary dentition. So that is something called as physiologic spaces. So these physiologic spaces are present so that they help in accommodating larger permanent teeth when they erupt. So this is a natural phenomena which we will not correct. Similarly, during the mixed dentition stage, another transient malocclusion called as ugly duckling stage is seen. So here, when the canines are erupting, they put a pressure on the roots of the central and lateral incisors, causing the crowns of the central and lateral incisors to diverge. So this will create a spacing between the two central incisors and also between the central and lateral incisors. So we see this around 8 to 9 years of age. This is again a transient malocclusion, and once the permanent canines erupt into the occlusal plane, these spaces usually close by themselves. Uh, so that is why we are calling it as a transient malocclusion. That means this stage does not require any orthodontic correction. It will resolve by its own once the permanent canines erupt into the arch. Even after the eruption of canines, if the midline diastema is still evident, then we will do orthodontic closure. One basic reason for spacing is tooth material arch length discrepancy. So either the tooth material is less, that is the teeth are small in size, or there are peg laterals. So that is also a common phenomena. Or the arch length, that is the arch is too wide. So why is this tooth material arch length discrepancy seen? It is genetic. If the patient is inheriting the small size from one parent and a larger jaw from one parent, so that can contribute to this generalized spacing. Especially for midline diastema, one common reason is abnormal frenal attachment. So when we have a thick fibrous frenal attachment in between the two central incisors, that can contribute to the space between the incisors. This can be how to know whether that frenal attachment is causing the spacing. We will do something called as Blanch test. So when we lift the upper lip up because of the tension in the frenum and its attachment to the gingiva, we can see blanching in the area of the connection of the frenal attachment to the gingiva. So this is a positive Blanch test. So that indicates that the attachment fibers are running into the in between the papilla and usually needs sectioning. Radiographically, what we see is a notching of the alveolar crest in between the two central incisors. So that is also a sign that we have abnormal frenal attachment, and the pull from those fibers may result in the spacing. Other common reason for either midline diastema or generalized spacing is presence of pressure habits. So tongue thrusting, digit sucking. When this happens for a prolonged time, it will have a buccal pressure onto the teeth. So this buccal pressure will result in flaring of the teeth, and as a result, we'll also see spacing between the teeth. So it can be confined only to the upper arch or to the upper as well as lower arch, or there could be some pathology between the teeth. So mesiodense is one common problem that we encounter. That is, we have a supernumerary teeth between two central incisors, which is creating the space. So once the mesiodens is removed, we can easily close the space between the teeth. So not only a supernumerary teeth, we can have cysts or abscesses between the teeth or odontomes which can cause the space. So if we see in the first picture in the X-ray, there is a compound odontome which has prevented the first premolar from erupting into the arch. Also, the premolar has shifted from its normal position with the resorption of the apex or probably a cyst formation. In the second picture, again we see a kind of a cystic formation between the two teeth, which has resulted in the teeth being pushed apart and a gap in between the teeth. So sometimes the diastema is iatrogenic. So iatrogenic is something we create in the process of treatment. So one classic example is the rapid maxillary expansion. So when we are expanding the palate, because of the palatal expansion, there is a because of the separation of the suture, there is a midline diastema between the teeth. There is no need to do any active treatment here because slowly that because of the transeptal fiber pull, the teeth will again come back together. Then if we see, it could have a racial predisposition, that is usually negroid race shows greatest incidence of midline diastema. Then also it could be a anatomic cause like macroglossia. So a large tongue which is not having enough room in the oral cavity will push the teeth on all sides. So this will cause flaring of the teeth and spacing. Sometimes premature loss of any permanent teeth because of caries or periodontitis will also result in a space between the teeth. So now we know the etiology. So once we know the etiology, our first step in correction of the midline diastema is to eliminate the cause. So in case of habits such as tongue thrusting or thumb sucking, we give habit breaking appliances. So something like a tongue grip or tongue spurs, so that the habit is eliminated. So once the habit is eliminated, we can we can do active correction of the spacing. So in case of a thick labial frenal attachment in the upper arch, we can do frenectomy to remove those fibers and allow the space to close without any resistance. And any pathology or mesiodense supernumerary teeth or cyst or abscess has to be first taken care of before we initiate the treatment for the closure of spacing. Once we eliminate the etiology, now for active treatment, we have to analyze whether it is just a simple space which can close with removable appliances, or we need a full-fledged fixed appliance therapy. So for a simple midline diastema, where there is some amount of overjet and no restriction from the lower teeth, we can give a simple removable appliance with split labial bow or with two finger springs, so that the teeth move towards each other. Or we can give springs like M spring locally from the lingual side. Similarly, in case of generalized spacing, we can still use these, or because we are trying to close the space over a large area and multiple teeth are being moved, fixed appliance will have better results. So here, when we do a full bonding and a fixed appliance, again we can use springs here if we are only dealing with the space between two teeth. Or for generalized spacing, we can give something called as elastomeric chains or E chains. So these are kind of rubber bands. They are stretchable materials or elastics, which when we place it over all the brackets, they pull all the teeth together, closing the space. So when the spaces are closed, the teeth even come back towards each other. So not only E chain, we can also give something called as E thread or elastic thread. So this is again a stretchable thread that we wind around all the teeth so that the spaces are closed. Apart from the elastics, we can also use closed coil springs. So a closed coil spring which we place in between the two brackets. So when we stretch the closed coil spring, it is activated. So once this activated spring is left in the oral cavity, the spring tends to come back to its original closed position. So when it is coming to its closed position, it will pull the teeth towards each other, closing the diastema. Similarly, we can give other simple or modified removable appliances like a split a 6 retainer with attachments where elastics can be run to close the space. This will be more useful in a relapse case where minor relapse happened and the space opened. So we can give some customizable appliance like this and close the space without going for a full-fledged fixed appliance therapy again. So once the active treatment is done, we have to think about retention. Why? Because spacing has a very high relapse potential. So one method is giving fixed retainers. So in the upper arch, we can give from lateral to lateral or canine to canine. If it's only a midline diastema case, we can just give a fixed retainer between two central incisors. In the lower arch, we can give from canine to canine. Apart from this, also use of removable retainers like Essex retainer or thermoplastic retainer, Beg retainer or Holly's kind of retainers can be given to hold the teeth in position. Then apart from this, we'll also do freenectomy. So sometimes freenectomy is done after the space closure because it is said that if we do freenectomy before the space closure, the scar tissue may prevent the spaces from being closed. So that is why once the space is closed, then we do freenectomy. So the advantage here is apart from removing the frenal attachment, the scar tissue that is forming will prevent the incisors from opening. It will prevent the incisors from going back to its original position or from the space from being opened. So apart from orthodontic treatment, for some spacings, especially if it is because of microdontia of lateral incisors or where there is minor spacing and the alignment is uh, well enough, so there whatever space is there is because of small size of the teeth. So instead of closing those teeth in the arch, we can go for prosthodontic solution, that is the use of veneers or crowns. So when we are doing this, we are establishing proper height to width ratio of the tooth, which will improve the aesthetics and also close the spaces. So in this case, again we see there's a midline diastema and the lateral incisors are also small. So veneers were given for the uh, anterior six teeth to establish correct golden proportion. So along with this mild designing, the spaces are also closed here. Similarly, in case of missing teeth, so that is also one common reason for spacing. So when we have missing teeth and there is sufficient space, we can directly go for prosthesis or implants to cover that space without opting for a orthodontic treatment plan. So in this case, in the bottom picture, two lateral incisors were missing, which were covered with implant prosthesis. And in the above picture of the midline diastema is closed with the help of a composite restoration. So this is a direct restoration which is used to close the midline diastema. So for the management of spacing, whether it is just the midline diastema or generalized spacing, uh, not only orthodontic options, we also have certain prosthodontic options. And for any treatment to be successful, first the cause has to be removed. So once we remove the cause, the stability of the treatment will improve.